Welcome to PGOG, postgraduate class in obstetrics and gynecology for postgraduates as well as consultants. Today's topic is management of stress urinary incontinence. We can divide the management in two parts as conservative management and surgical management. Weight reduction can be the part of conservative management, and with the weight reduction there is a reduction in severity, but it is difficult to maintain the weight reduction, and it has been seen in the long-term studies that persistence of the benefit is not seen with the weight reduction. Second component of conservative management is pelvic floor muscle exercises, which are also called as Kegel exercises, where under the physiotherapist supervision, if it is done, then it has been found to be more effective as compared to the unsupervised pelvic floor muscle exercises. In these exercises, what is being done is, what is to be achieved by the patient is internal tightening and lifting of the pelvic floor. Various vaginal devices are available, which also are the component of conservative management, and where continence pessaries are available for the use in patients who have stress urinary incontinence alone. And if patient has both SUI as well as pelvic organ prolapse, then in that case continence dishes or continence rings are available. What we need to understand and remember is estrogen replacement therapy. If it is tried in post-menopausal women thinking that estrogen deficiency might be leading to SUI, stress urinary incontinence, it has been seen by studies that ERT is of no use as a treatment for SUI. On the other hand, there is in SUI. ERT as compared to those who did. Now coming to the surgical options, before surgical options, let us see what are the prerequisites. How can we decide in which women we can proceed with surgery for stress urinary incontinence? First is there has to be objective evidence of stress urinary incontinence. And if there is a doubt, then pyridium pad test can also be done, especially in sports persons where it is difficult to demonstrate the urinary leak on the examination table, even in a standing position also. So in these cases, pyridium pad test can be done, which can help us to see whether really there is a leakage with the vigorous exercise. And secondly, there should not be any evidence of urinary retention. That means residual urine assessment should be done, and if it is normal is less than 50 ml, but up to 150 ml is permissible. Greater than 150 ml, it indicates that there is some urinary retention, which might be because of either obstruction to the outflow tract, or it can be because of the detrusor muscle functioning problem. Dysfunction in the detrusor muscle itself can also lead to urinary retention. So presence of urinary retention, you don't proceed with the SUI surgery. So these are the two prerequisites. Now let us start with this various surgeries which are being used for treatment for this stress urinary incontinence, and the mainstay is mid-urethral sling surgery. It was introduced by Ullstein in 1996. Now we have already seen in the last lecture on SUI that Ullstein was the one who had proposed integral theory as a pathogenesis for stress urinary incontinence, where integral theory says that there is a weakness in the pubourethral ligament, and that or pubovaginal ligament or pubourethral part of the pubovaginal ligament, and that is the reason why there is a anterior vaginal laxity that leads to the stress urinary incontinence, and that is why he was the first one who introduced this mid-urethral sling surgery. name is Ulmstein. Now there are two types of mid-urethral multi-incision sling surgeries, full-length sling surgeries. Now you need to understand that there is a difference between there is a need to use this multi-incision because now there are newer procedures where only a single incision is being given as procedure for mid-urethral sling. So what here we are discussing are the multiple incision where there are three incisions. First incision is over the anterior vaginal wall and two more skin incisions are present, and these surgeries are the mainstay in the mid-urethral sling surgery because these are found to be equally effective. Both types of surgeries are equally effective. This mid-urethral multi-incision full-length slings. Though these are equally effective, these are the surgeries which have been studied maximally, and the strong evidence is there to indicate its even long-term efficacy also, as opposed to some newer surgical options. So there are two types of these mid-urethral slings. First is retropubic sling surgery and other is a transobturator. Retropubic, as the name suggests, the sling goes behind the pubic symphysis. Transobturator is where the sling is entering into the obturator foramen. What is being used for this mid-urethral sling surgeries is type 1 polypropylene macroporous mesh. These postgraduate students need to remember this name, type 1 polypropylene macroporous mesh. This is only recommended by various guidelines because it has the least foreign body reaction and infection rate is also minimum with this type of the mesh. Now, how does it work? This mid-urethral sling surgeries. Female urethra, it is short, the length is only around 4 centimeters, and distal two-third of the urethra remains in very close proximity to the vagina. Now, this mesh provides support to the pubo-urethral ligament or pubo-vaginal ligament. It is providing the support, in other words, to the anterior vaginal wall itself. But if this sling is used with excessive tension, it leads to urinary retention, and that is why whenever these slings are being attached, what we need to remember is there has to be a tension-free urethral support. Correct placement at the middle one-third of the urethra is very, very important, and this how it corrects SUI is explained by the De Lance's theory of stress urinary incontinence, where hammock theory has been proposed by De Lance, and by the other theory is the integral theory, which we have already seen in the last lecture in detail. Those who have not gone through that, please go through that lecture first so that you will understand how these mid-urethral slings work. What is happening here is this sling is there, and whenever there is a raised abdominal pressure, urethra gets compressed against this sling, and that is how it prevents the incontinence with the raised abdominal pressure. That is how it leads to the cure for stress urinary incontinence. What is important to understand is this mesh should not be too much near the bladder neck. It will lead to retention if it is near the bladder neck. It should not be near the distal one-third over the distal one-third of the urethra. In that case, it will not be effective in prevention or cure of this stress urinary incontinence. That is why importance is middle one-third of urethra where it needs to be placed. That is why the name goes as mid-urethral slings. Now about the mesh used in SUI surgery, FDA has had raised the concerns about the use of mesh in pelvic prolapse surgeries in 2011 itself, and that is why there was so much of concerns about the complications which were arising because of the use of mesh, and that is why this use of mesh, especially in pelvic organ prolapse, prolapse surgeries, has reduced to a great extent for vaginal surgeries. Wherever now it is being used, it is used for abdominal correction of pelvic organ prolapse, especially with the help of laparoscopy. But vaginal surgery's use of the mesh has gone down significantly because of the concerns related to the complications because of the use of mesh. But no such concerns for the mesh use are seen with the stress urinary incontinence. Long-term high-quality studies are available showing safety of mesh use in SUI surgeries. Multi-incision full-length mid-urethral sling procedures are found to be safe by FDA, and that is why there is a less concern about the use of mesh in SUI surgeries as compared to the use of mesh in pelvic organ prolapse surgeries. Now we will start with the surgeries. First, as mid-urethral sling surgeries, where mainly two types are there: retropubic and transobturator. As I said, I have already told, retropubic is where the sling or the mesh is passing behind the pubic symphysis or pubic bone. To be precise, not pubic symphysis, but behind the pubic bone. Whereas transobturator is where it goes in the traverses to the obturator foramen. Now, the first mid-urethral sling surgery which was introduced was retropubic in 1996, and after a few years in 2001, transobturator technique was introduced. Both are showing equal efficacy with a high success rate of 80 to 90%, with whether we do retropubic or transobturator. Efficacy is almost same, which has been proven by various studies. What is most important for efficacy, we have already seen in the last slide, is mid-urethral placement is important, whether we are doing a retropubic sling or transobturator sling. Retropubic sling is also known as tension-free vaginal tape or TVT. So if you read the previous textbooks or previous even studies also, you will find that TVT is used in place of retropubic mid-urethral sling. But now the new editions of the textbooks are using retropubic mid-urethral sling and not TVT. So that there should not, even guidelines are not using TVT because there can be a confusion. If you say TVT, it holds true even for transobturator. That also is tension free, and that is why to have the precise communication, the terminology which is preferred at present is retropubic mid-urethral sling surgery and transobturator mid-urethral sling surgery. This transobturator is also known as TOT, transobturator tape. TVT is tension-free vaginal tape for retropubic. What is done in both the procedures is 1.5 centimeter vertical incision is given on the anterior vagina, and the upper end of the incision is 1 to 1.5 centimeters below the urethral orifice. So this initial step is same whether you plan to do retropubic sling or transobturator. Second step is also same for both, that a 2 centimeter tunnel is created with the sharp scissor dissection, which from this vertical incision, which is 45 degrees to this vertical incision, and that means it is going towards the junction of the pubic bone with the inferior pubic ramus. So the dissection should not be perpendicular to the vertical incision. It should not go in a transverse direction, but it goes upwards in oblique direction. That is why it is said that we do the dissection with an angle of 45 degrees, and around 2 centimeter tunnel is created with the scissors by lifting up the vagina, and till by that time, by the end of 2 centimeters, usually the scissor hits the pubic bone. Now, when retropubic mid-urethral sling surgery is being used, we have to introduce a rigid catheter to the Foley's catheter to push the bladder base to opposite side whenever we are using the this trocar, and we are passing the trocar from this tunnel to the skin incision. So this rigid catheter is passed so that we shift the bladder base to the opposite side, push the bladder base to the opposite side to prevent injury to the bladder base, as the passage of the trocar is just by the side of this bladder base. This step is not required in trans obturator as trocar is not passing just by the side of bladder base, it is passing more laterally, and that is why this step is not required in trans obturator sling. Now for retropubic sling, specially designed trocar is available with polypropylene mesh attached to it. Especially the specific shape is there so that it passes behind the pubic bone and emerges through the skin incision out of the which is over the abdomen. So this vertically it passes, and for that the specific design of this trocar is there, which helps us for the passage of the trocar just behind the pubic bone. Whereas for transobturator, helical trocar is there with polypropylene mesh, which passes in a curved manner. You can see it passes like that and it enters into the obturator foramen. Now, skin incision for retropubic are over the abdomen, lower abdomen, whereas skin incisions for transobturator are in the groin. The exact location of the skin incisions is important. With a sharp dissection, skin incisions are created for retropubic, which are 2 centimeter lateral to the midline and just above the pubic bone. So the finger has to roll over the pubic bone, and we may need to make an incision over the superior border of the pubic bone as near to the pubic bone as possible, because we do not want to enter into the peritoneal cavity. We want to avoid entering in peritoneal cavity. We want to remain in the retropubic space, and that is why this incision has to be very close to the pubic bone, 2 centimeter lateral to midline and just above the pubic bone. That is the exact location. Whereas the skin incision for transabturator is in groin, it is the incision is at a higher level, superior to the level of urethra. It is 2 centimeters above the urethral orifice, and it is usually in line with the clitoris, and should be 2 centimeter lateral to inner thigh fold also. So there is a thigh fold which we can see over the legs, and 2 centimeter lateral to that and 2 centimeter above the urethral orifice is the exact location of the skin incisions for the transobturator sling. So we need to make these incisions first, and then we need to start pushing the trocar from this tunnel to this uh, demarcated or already made skin incisions. With the retropubic, the trocar will go just behind the pubic bone like this vertically, whereas here the trocar will enter into the obturator foramen. Now for retropubic, bottoms up approach is safer as compared to upside down approach. That means we always need to start from vaginal end to put the trocar, and then trocar will go to the suprapubic skin incisions. Whereas for transobturator, both approaches have been described to be equally effective inside out or outside in. That means either you can start from the skin incision and then come to the vagina as outside in approach, or we can start from vagina and then go to the obturator to the obturator foramen and then through the skin incisions. So both the approaches have been described. It is up to the surgeon's uh, practice and surgeon's preference that one can do either inside out or outside in approach for transobturator. Whereas if you try a side down approach with the retropubic, the complication rate is more. Other injuries are more, and that is why it is not recommended. Bottoms up is you start at vagina and then go up. With retropubic, the complications are increased bleeding is there, as if you go lateral to the your skin incision is not 2 centimeter lateral to midline, or your trocar entry is not towards the skin incision and you go lateral. Even if you shift by 2 to 3 centimeters, major vessels are there. You are likely to injure external iliac artery or vein, or plexus of Santorini can also be. Now this plexus of Santorini is present in the which venous plexus is present in the paravaginal tissue which drains in internal iliac vein. and this also can get damaged when we are placing this trocar for the retropubic sling. So bleeding is comparatively more with the retropubic sling as complications, excessive bleeding, hemorrhage are more with retropubic as compared to transobturator technique. Bladder injuries are seen more frequently with retropubic as compared to this transobturator. There is increased complication of urinary tract infection, and urinary retention is also more frequently observed with retropubic as compared to transobturator mesh. With transobturator increase, the complication which is more frequently seen as compared to retropubic is there is increased risk of mesh exposure. Now, whenever there is a mesh exposure, patient can present with constant pain, dyspareunia, there can be excessive vaginal discharge also, and we need to remove the exposed part, and then we need to suture the vagina if it is an exposure in vagina. And it is usually seen if vaginal incision is too superficial, but the mesh exposure also can rarely be in the bladder or even in the urethra also has been reported, and in these cases the complications are more, pain is more, hematuria can also be there, recurrent infections can be there with the foreign body in the bladder or urethra, and there the surgical corrections are also comparatively uh, more difficult. So though here we should remember that these are the complications which have been noted in the literature with transobturator also. There is increased risk of urethral injury with the transobturator as compared to the retropubic technique. If vaginal incision is given too deep, then there can be a urethral injury, and if urethral injury occurs when we do this any of the procedure needs to be abandoned. We need to suture the urethra and keep the catheter for 1 to 2 weeks. That will be the treatment. We cannot proceed with the remaining part of the procedure if there is a detection of urethral injury. Now, transobturator it has become slightly more popular as compared to retropubic, though both are having same efficacy. It is in severe SUI, it is less effective as compared to retropubic, but it is associated with less risk, especially complications such as bleeding, bladder injury. These are less with the transobturator as compared to retropubic. Now, whatever SUI surgery we do, we have to remember that cystoscopy, even in for these mid-urethral slings, when trocar is in place, before removal of the trocar itself, we need to do the cystoscopy, you rule out bladder perforation, and then only we can proceed with the remaining part of the surgery. So, cystoscopy is mandatory for all SUI surgeries. This is the principle, or this is the rule. As diagrammatically you can see, and I request postgraduate students to practice drawing this diagram. Anatomically, as we can see here, this is the pubic symphysis. This is the pubic bone with the white part is the superior pubic ramus, and this yellow part is the inferior pubic ramus. This superior pubic ramus and inferior pubic ramus together are there is a defect in between. These are forming this obturator foramen. Now this is here is the pubic tubercle, so that whenever we insert the trocar in the retropubic trocar insertion, it has to be directed towards the pubic tubercle. That is why we need to know this anatomical landmark. This is the skin incision for retropubic, which is 2 centimeter lateral and just above the pubic, lateral to the midline and just above the pubic bone. Whereas for transobturator, we make an incision which is 2 centimeter above the urethral orifice, usually in line with the clitoris, and 2 centimeter lateral to the inner thigh fold. So transobturator, now this is the vertical incision. As we have already seen, it has to be 1.5 centimeter incision over the anterior vaginal wall, and the upper end of the incision is 1 to 1.5 centimeters below the urethral orifice. Once we give this incision, Then we have to invert this lateral edge of the incision, and with the scissor, sharp scissors, we have to create a tunnel. And tunnel is not created in a horizontal direction like this, but it is created obliquely in an upward direction with an angle of 45 degrees with this vertical incision, so that the tunnel is directed towards the junction of this pubic bone with the inferior pubic ramus. So it is like that. Obliquely it is created. You create it till the scissor tip hits the bone. That will be the pubic bone or inferior pubic ramus. For this retropubic sling, the trocar is now passed after creating the tunnel in a vertical direction. It has to be as near to the pubic bone as possible. As you pass this trocar upwards, you need to remember that the tip of the trocar should not go laterally, otherwise there can be severe hemorrhage. Even deaths are reported with the injury to the external iliac vessels. So we need to always have a control entry of the trocar in the retropubic space. With the tip of the trocar, we have to focus on that it remains in close proximity to the pubic bone, and retropubically behind the pubic bone it emerges abdominally through these skin incisions. Then you need to see to it that there should not be any tension over the tape by keeping a Hagar's dilator, number 9 dilator, so that it is a tension free tape or a mesh. Whereas for transobturator, it will be going till you go beyond the superior border of this inferior pubic ramus, and this helical trocar tip enters into the uh, through the skin incision. It enters into the obturator foramen, and then it enters through the skin incision. This diagram I want all the postgraduate students to practice, so that it becomes easier for you to understand, as well as if you get a theory question on SUI surgery, surgical management of SUI, you need to draw this diagram. Now coming to the newer technique for this mid-urethral sling, which has been introduced in last few years, it is called as single incision mini slings, SIMS. Now for the standard or popular mid-urethral sling, it is called as multi-incision, because we have already seen there are 3 incisions. One is over the vaginal, anterior vaginal wall, and 2 incisions are on the skin. But here it is a single incision over the vagina, anterior vaginal wall, and a shorter mesh is used. Here we are using longer mesh, which goes to the retropubic space and then emerges through the skin incisions, or it goes to the obturator foramen. Comparatively, here the mesh which is being used is shorter. Mesh is anchored or fixed to the fascia in the obturator or retropubic space. So either it can be anchored to the obturator fascia in the obturator over the obturator foramen, or at the retropubic space. It is a comparatively a newer option or emerging option, but whatever studies are available, few studies are available, and especially long-term data is still at present not available. But whatever studies are have shown that it is less effective. The efficacy for the correction of SUI is less with these mini slings as compared to the tension-free vaginal tape, that is retropubic mid-urethral sling, or transobturator tape, that is trans obturator mid-urethral sling surgery. It has been approved by American Urology Association with SIMS, that is single incision mini slings, are approved by AUA at present, but not by NICE guideline. Now for students, NICE, remember, it is the guideline by UK government of United Kingdom. So it is so many times if you want to see the RCOG guideline, it says that the guideline has been replaced by NICE. So this for SUI also we have NICE guideline 2019, and that NICE guideline says that mini slings are to be these SIMS, single incision mini slings, are to be used only for research. These are still not to be used in clinical practice, and the main concern is about the efficacy. Till that strong data is available about the long-term efficacy, I think it will remain as experimental as far as NICE guideline. But for American Urology Association guideline, NICE guideline we have 2019, whereas American Urology Association guideline has been updated in 2023. It is as recent as that. By AUA, they have considered the latest evidence, and that is why they are proving that it is a surgeon's choice whether to proceed with a retropubic transobturator or mini-sling. For all three, equal importance has been given. Now, coming after this mid-urethral sling surgery, the next popular surgical technique is Birch suspension. It is also a type of retropubic urethropexy. As the name suggests, you enter into the retropubic space of radius, and you do the urethropexy. That means you fix the urethra to a strong support. Here what is done in short is two bilateral sutures are taken, which are extending from Cooper's ligament or iliopectineal ligament to the endopelvic fascia surrounding the bladder neck. So that is how from bladder neck to the iliopectineal ligament or Cooper's ligament, two sutures are taken on both the sides. That is what is done in short in Birch suspension. Here mesh is not being used. The advantage over the mid-urethral slings is complications which are because of the mesh use, mesh exposure, mesh erosion. That is not seen with this Birch suspension. Another advantage is it can be done with an open technique, or it can even laparoscopically also it can be done, and that is why it is becoming more and more popular in the laparoscopic surgeons. Retropubic approach needs to be taken, and that is why the surgeon needs to have the complete idea or clarity about the anatomy in the retropubic space. It is comparatively less popular because of the more complications than mid-urethral slings in United States, but it is recommended as one of the in the list of surgeries given by NICE UK guideline. They have given it as number one procedure. So I think it depends on the local evidence also, which one comes at the top of the list. But for UK guideline, Birch suspension is at the top, whereas for US guideline, mid-urethral slings are at the top. Another next option is pubovaginal sling surgery. It is a very good option whenever it is a severe SUI or whenever the urethra is rigid or immobile. In these such patients, the results are better as compared to other techniques for the SUI. What is used here is an autologous graft, that is strips of rectus sheath are used. Patient's own rectus sheath strips are used. Mesh is not used, that is another advantage. Sling is placed at the bladder neck, whereas with the mid-urethral slings, we have already seen that the sling is at the middle one-third of urethra, whereas here with the pubovaginal sling surgery, it is at bladder neck, as well as with Birch suspension also, sling is placed at the bladder, near the bladder neck. It is good for rigid urethra with severe SUI. Retropubic space needs to be entered, and that is why the complications such as excessive bleeding, hematoma formation, bladder injuries, all these complications are seen because if there is a previous, especially patient has got a previous surgery, suppose in the retropubic space, then adhesions might be there, and then there can be difficulty and complications might be more. One transverse abdominal incision is given to create this rectus sheath grafts, and these are then brought down through the retropubic space, and one vaginal incision is given mainly to enter into the paraurethral area in the region of bladder neck, and these slings, this rectus sheath graft is attached near the bladder neck. Now coming to occult SUI in pelvic organ prolapse. We have already seen in the class on pelvic organ prolapses, there are some patients where if you reduce the prolapse or you surgically correct the prolapse, then patient has stress urinary incontinence. Then this is the definition of occult SUI. So if patient has occult SUI, you get a patient of pelvic organ prolapse, you examine the patient and you find that you reduce the prolapse, keep it in anatomical position either with the help of a ring pessary or by putting the vaginal packs, and you find that then patient complains of stress urinary incontinence, then she is a case of occult SUI with pelvic organ prolapse. So here are three approaches are available. You diagnose and you operate simultaneously if there is an occult SUI in a case of pelvic organ prolapse. Second option is you operate if necessary as a second separate surgery in occult SUI. That is also an option which is also a safer option sometimes, because then we can see the severity of SUI and decide the technique which needs to be used. Third is to do prophylactic this stress incontinence, urinary incontinence surgery for all patients wherever you are doing a pelvic organ prolapse surgery. There is a big question mark for this approach that as it has been seen that it increases the complications rate because of this SUI surgery, which adds to the complications of surgeries of the pelvic organ prolapse, and that is why it is not recommended by most of the guidelines at present. Now, what guidelines say is it has to be a shared decision after patient counseling. Whether if you diagnose occult SUI, you need to explain to the patient that there are two options. Either you can proceed with the correction in the same sitting, or you can do it as a separate second sitting, and depending on the patient's opinion, you take a shared decision. Chances of failure of mid-urethral sling surgeries are more when these are done simultaneously with anterior colporrhaphy. The main reason is the incision of anterior colporrhaphy is a long one, inverted T or a vertical incision we give for anterior colporrhaphy, and this sling sometimes slips towards the distal one-third of the urethra, and then in that case the efficacy is reduced. So failure rate will be more. What is recommended is a separate vaginal incision should be given for mid-urethral sling when it is done along with anterior colporrhaphy. So anterior colporrhaphy incision, you stop quite below the urethral orifice. Give a separate incision 1 to 1.5 centimeters below the urethral orifice to put the mid-urethral sling. That is the meaning of this sentence. But if you are doing laparoscopically sacral colpopexy and you are combining it with the Birch colposuspension for treatment of SUI, then it is a good option. Both can be done laparoscopically or both can be done as open surgery also. But for mid-urethral slings, there is some apprehension when it is combined with anterior colporrhaphy about the failure rate, increased failure rate of the mid-urethral sling. Now, for those women who are not surgically fit, there is another new option is of use of urethral bulking agents. These are injected submucosally in the urethra near the bladder neck. This can be injected transurethral or periurethral by doing cystoscopy. Failure rate is more as compared to the other surgical options, and repeat injections might be needed. Comparatively, this is a new technique and long-term data is still not available, but this can be used for women who are surgically unfit. The most recent in the surgeries for stress urinary incontinence, the latest or recent advances, there is a research which is going on about the use of stem cell therapy. Stem cells are autologous stem cells which are derived from either adipose tissue or muscle the patient, and these are injected either near the bladder neck or these are injected in the pelvic floor to improve the strength of pelvic floor, and this is at present under research. It has also not been advocated for a routine clinical practice because still the efficacy and complications because of that, these are not fully understood. So it is under research. Now, in short, about the recommendations of American Urology Association 2023 for SUI or stress dominant mixed urinary incontinence. Clinician may offer pelvic floor muscle exercises, continence, pessary, vaginal inserts as non-surgical options to the patient. Whenever patient opts for surgery, then preoperative counseling must include the details about the efficacy and risk of all the procedures. Mid-urethral slings, autologous pubovaginal sling. Autologous is where rectus sheath is being used. Birch colpoceps suspension, either open or laparoscopically, and bulking agents. So about all this, the patient needs to be educated mainly about the efficacy and risk. In the mid-urethral slings, they have included all the three: retropubic sling, transobturator sling, as well as single incision mini sling. Now, if you see NICE 2019 guideline, there is a change, complete different opinion emerges when we compare these two guidelines. American Urology Association and NICE guideline, there is a shift in the opinion. Here, colpo suspension comes at the top of the list, either open or laparoscopically, where we do the Birch colpo suspension. Second comes autologous rectus spatial sling. And then third option is mid-urethral retropubic sling. That is mainly because there is a concern about the complications because of the mesh which needs to be used in all these mid-urethral sling surgeries. And in the sling surgeries, they are mainly talking about retropubic sling. Now there is a useful recommendation by NICE. A surgeon might consider using colored mesh for use of placement as well as removal if there is a mesh related complication such as mesh erosion or mesh exposure. This colored mesh will be easier to remove also. Top-down retropubic sling surgery technique or single incision slings are not recommended at present in clinical use. This can only be done as for research purpose only. These are not recommended in routine clinical use. Transobturator sling is also not recommended as a first option. If there is a contraindication to do retropubic sling, such as because of the previous retropubic surgery or adhesions there, then only as a second option one can try and do this transobturator sling surgery. And the main reason might be the increased failure rate in severe SUI with the transobturator as compared to retropubic sling. Intramural bulking agents are advocated by NICE if patient is not suitable or not willing for surgery. If there is a pelvic organ prolapse, in pelvic organ prolapse, preventive surgery for SUI is not recommended. If there is a occult SUI, then only we can proceed with either operating in the same sitting or in a second separate sitting. But concurrent surgery for POP and SUI can be done as per the patient after doing a proper patient counseling. Procedures which are presently not recommended by any of the textbooks and guidelines because of the high failure rate are Kelly's plication of the bladder neck. When I was doing post-graduation, we were taught this Kelly's plication, that you do anterior colporrhaphy, you further do the dissection near the bladder neck, and then you plicate the tissue, paraurethral tissue. That was Kelly's plication, which was a popular surgery thought to be for mainly for this cure of SUI, but it has very high failure rate, and that is why it is no more. It is not recommended by any of the textbooks or guidelines. Marshall-Mancetti-Kranz operation is a type of retropubic urethropexy where the from the bladder neck the These sutures are taken over the periosteum of pubic symphysis. It is associated with more bone infections, osteitis, and that is why it is no more being recommended whenever now we do the retropubic urethropexy. It is the Birch Palpo suspension which is preferred, or retropubically pubovaginal sling is done. Needle suspensions were tried for a few years, where sutures were taken from the bladder neck and they were attached to the rectus sheath. But because of the high failure rate, this technique also has been abandoned. So surgical options mainly which are emerging are mid-urethral sling surgeries, colpo suspension, mainly the Birch colpo suspension, and pubovaginal sling, where the autologous pubovaginal sling is the which has emerged as the favorite option. Now, if we see mid-urethral slings, if we have three types, that is the mid-urethral sling, where you do the tension-free vaginal tape, that is the retro pubic mid-urethral sling. Transobturator tape is where you do transobturator mid-urethral sling. So either you do retropubic or transobturator, and these are single incision mini slings. These are also the latest addition to the mid-urethral slings. As per American Urology Association, there is importance given equally to all these three, and it is surgeon's choice and pay after at the end of the patient's counseling, you decide either of these three procedures. But if you see the textbook Steeland's Operative Gynecology or Novak's textbook of gynecology, there is a question mark which is being given to at present about these single incision mini slings, because the failure rate seems to be more as compared to the standard mid-urethral slings. Colpo suspension can be done as open technique or laparoscopy technique, and by NICE guideline, it comes at the top of the list, followed by pubo-vaginal sling surgery with the use of rectus sheath. Now, pubo-vaginal sling surgery is the number one whenever there is a severe SUI with a rigid or immobile urethra. In these women, especially, it comes at the top of the list. Whereas as far as NICE guideline goes, for mid-urethral slings, they are considering mainly retropubic sling only. And if there is any contraindication for retropubic sling, then only we can try this transobturator sling. Whereas this single incision mini slings are at present not at all advocated by NICE in the clinical practice. Thank you so much. These are the references. Hope that you have understood, because what happens is so many times this stress urinary incontinence remains neglected in many women. Whenever you get a case of pelvic organ prolapse, you need to reduce the prolapse and see whether patient has got, or so many times patients are hesitant. They do not come forward unless you ask specifically about this history of SUI. But it leads to so much of social embarrassment. It affects the quality of life adversely by affecting the social life, or psychologically, physically also it affects a woman. So we need to positively ask the woman by leading questions about the history of SUI. And I hope that with the better operative techniques which are now available, young generation of gynecologists will become proficient in operating for the SUI, so that this hidden morbidity will also be taken care of. Thank you once again.